This is a doctor-patient discussion from an antenatal clinic. Let's discuss what we can learn from it. We're going to break it down into 12 key phases, which include elements of reflection, empathy, and patient-centered care. This is something that examiners often look out for and is ideal for your OSCE prep, educational scripting, or reflective practice. So, let's get started. Phase 1, opening and reason for visit. Doctor. Hi, I'm the doctor. You're here because your GP has referred you for your first antenatal check. And I just want to confirm that you're seeing me for the first time. Is that right? She confirms that she's 6 weeks pregnant. The doctor starts off with open-ended questions to assess how things are progressing. Phase 2, symptom review and early pregnancy risks. The doctor is screening for red flag symptoms, which could indicate an ectopic pregnancy or a threatened miscarriage. So he asks, are you having any vaginal bleeding or spotting? Any abdominal pain, breast tenderness, nausea, or and she says that everything is fine. Phase 3, obstetric history. Now we know that there is no acute concerns. The doctor explores her obstetric history. He knows that she has had 2 previous so he asks about the circumstances surrounding those pregnancies. For example, when did they occur? What were the symptoms? Was there an ultrasound done? Did they have a cause? What happened this time around? Was it managed conservatively like the last one? If it was, what did that entail? How did it happen? It's important to ask about associated symptoms like pain, fever, and what investigations were done previously. If they were told there was a cause for the miscarriages, then asking about that is really important. If not, saying that we don't have an explanation for it this time is also important. Phase 4, medical history. He screens for diabetes, hypertension, thyroid disease, PCOS, fibroids, STAs, and HIV. And she has no medical conditions, so he doesn't need to explore any of these further. Phase 5, lifestyle and social history. Now we know there are no acute red flag symptoms, and her past medical history is unremarkable. He moves on to asking about smoking, alcohol, drugs, living situation, occupation, and so on. All of these are important to establish as they can impact the current pregnancy and increase the risk of adverse outcomes. For example, smoking increases the risk of miscarriage, stillbirth, prematurity, and low birth weight. Phase 6, menstrual history. This is also an important part of the history, as it may help identify some of the causes of her Some of the things the doctor could have asked about include regularity of periods, pain during periods, duration of bleeding, and any intermenstrual bleeding. Unfortunately, this information was not provided in the clip. Phase 7, examination. The nurse has already done a full set of vital signs, and they're all within normal limits. She has also done a urine analysis which was negative for infection and protein. The doctor does a general physical examination and an abdominal examination, checking for any fetal heart sounds. He also measures her height and weight. There are no abnormalities. Phase 8, investigations ordered. The doctor orders some blood tests, including a blood group and a screen for rubella, syphilis, hepatitis, and HIV. He also wants to do a blood sugar test, as she is newly diagnosed with diabetes. An early pregnancy ultrasound will be arranged to assess the viability of the pregnancy and to date it accurately. Phase 9, patient concern. The patient asks, why did the miscarriages happen? This is a very natural question and a very difficult one to answer. The doctor explains that most first trimester miscarriages are due to chromosomal abnormalities or placental issues. Sometimes no cause is found. However, there are some well-known risk factors, including maternal age, over 35, smoking, alcohol, obesity, infections, and certain medications. Phase 10, counseling and reassurance. The doctor uses this opportunity to reassure the patient that most women go on to have successful pregnancies despite previous He reiterates that lifestyle changes such as no smoking or alcohol, a healthy diet, and avoiding infections will help reduce the risk of future He mentions that if she has 3 or more miscarriages, they might need to do further investigations. Phase 11. Further testing. If there are recurrent miscarriages, the doctor explains the further tests that might be offered. These include an ultrasound scan to assess the structure of the womb and the cervix, a 3D scan to get a detailed view of the pelvic anatomy, a karyotyping to check for any genetic abnormalities, and some blood tests to check for APS antibodies and the lupus anticoagulant. These are the ones linked to clotting and placental issues. Phase 12. Safety advice. Finally, the doctor gives her some safety advice. He tells her to contact her GP or the early pregnancy unit immediately if she experiences vaginal bleeding or any other concerning symptoms. So what did we learn from this consultation? We learned that the discussion was structured and logical. The doctor demonstrated empathy and understanding throughout the conversation. He actively listened to the patient, explored her feelings, and explained things clearly. He also provided reassurance and shared decision-making. That's all for now. See you next time!